Hi, everyone. Welcome to the 17th episode of Dose of Derm, a dermatology guide for medical students. My name is Emma Holjak.
And my name is Iryna Savinova, and on today's episode, we will be interviewing Dr. Perla Lansang. Dr. Lansang is a full-time staff dermatologist and associate professor in the Division of Dermatology at the University of Toronto. She is based at Sunnybrook Health Sciences Centre, where she served as division director for 3 years. Prior to that, she was the Director of Undergraduate Education for the Division of Dermatology for over 10 years. She is also cross-appointed at the Section of Pediatric Dermatology at the Hospital for Sick Children, where she runs a pediatric psoriasis clinic, and in the Division of Obstetric Medicine at Sunnybrook Health Sciences Centre.
She completed her medical school and dermatology residency at the University of Philippines-Philippine General Hospital, having done fellowships in pediatric dermatology at the Hospital for Sick Children and in advanced medical dermatology at Sunnybrook Health Sciences Centre. Dr. Lansang's practice is a mixture of pediatric, adolescent, and adult dermatology, with a special focus on psoriasis, atopic dermatitis, pregnancy dermatoses, autoimmune bullous disease, and general medical dermatology. She has a special interest in immune-mediated skin diseases and has extensive clinical and research experience in many areas of immunodermatology. Without further ado, we are excited to introduce to you Dr. Lansang.
Thank you for having me.
Thank you so much for joining us here today. To get us started on this episode, we were wondering if you could share a little bit about your medical school journey and your path to finding and pursuing dermatology.
So, as you mentioned, I didn't do my medical school or residency here in Canada. I trained in the Philippines. I did med school in the Philippines. And really, we weren't lucky enough to have a clinical experience in dermatology when I was in medical school. I distinctly remember a lecture on immunobolus diseases. I remember one of our preceptors talking about pemphigus and pemphigoid, and I was just so fascinated with her before and after pictures. I had never seen anything like that. So that sort of got me interested in dermatology. The other thing I was interested in was medicine, like internal medicine. So I was choosing between the two, and then I realized there's so much internal medicine in dermatology. And then plus you have, the cool thing about watching the skin disease practically melt away. And so that sort of got me really interested in the field.
I really like how you said that, watching skin disease melt away, especially with all the advancements and the biologics now. It really feels like that is actually what is happening.
That is one of the fun things about this specialty. I mean, maybe we'll talk about that more later.
Sure. We also saw that you did a lot of training, and you have a lot of interesting niches, especially within pediatric dermatology. Can you tell us a little bit about how those trainings came about and how you decided to specialize in those areas?
So that was a lot of serendipity combined with interest. My husband and I, after our residencies in the Philippines, wanted to do fellowships outside the Philippines to bring something back. Actually, we had no plans of staying in Canada. So I remember emailing Neil Shear, who was the head of dermatology then, and I just said, "Do you have any fellowships available?" My interests are pediatrics. I also really liked drug rashes, like adverse drug reactions, and medical dermatology in general. And so we emailed back and forth. A fellowship opened up magically. He actually was going to Manila in like 10 days after I had emailed him. I mean, what are the chances? And so I did meet him in Manila. We chatted about the fellowship opportunities. And before I knew it, we were here in Canada. My husband had a fellowship as well. So we were lucky enough to both get fellowships here. And then one fellowship turned into two turned into three, and then I never left.
Wow, that truly is coincidence that 10 days after, that's how it worked out.
Yeah.
Yeah, that's very cool. We were also wondering if you could tell us a little bit about what your practice looks like currently and what other roles you hold.
So my practice is very heavily medical. I see a lot of general dermatology. There's practically nothing I won't see. I'll see, as I mentioned, inflammatory diseases like psoriasis, atopic dermatitis. I see some cutaneous lymphoma. I see kids, teenagers, adults. I see everything. I mean, as a dermatologist, it's hard not to see skin cancers. That's sort of like bread and butter, but I much more enjoy medical dermatology. I like minor procedures. I'll cut out small things, but like surgery of big skin cancers is not something I love. I would rather kind of do the immunologic part of dermatology. So a lot of my practice is that.
Is it, since you see such a wide variety of different like cases and even ages going all the way from pediatrics to like adults and elderly, is it difficult kind of flipping between seeing those different types of patients?
Not really. I like to look at it as it keeps things fresh and interesting. You know, I also don't restrict my practice. So on a day-to-day basis, I see like really cool things. And of course, a lot of my practice is I have a very big biologics and advanced systemic medications practice. So that's a lot of atopic dermatitis and psoriasis and autoimmune blistering diseases. But really, I feel like every time I come to clinic, I don't know what's going to walk through that door. Of course, I see the referrals beforehand, but I think that keeps things exciting. It keeps me excited about the specialty, keeps me reading about new things. It makes teaching much more interesting. And that is a big part of what I do. That's why I'm in academic dermatology, because I love teaching, and that's why I did undergrad for so long, because I do enjoy having learners in clinic. I wish we could have more, but unfortunately, just from a logistics perspective, we can only take so many. But I find that as a teacher, as an educator, it is nice to talk about different things with learners.
That's super exciting to hear. I think that you are one of the first people to talk about pediatric dermatology on the episode as well. So coming with those insights and that perspective, can you talk a little bit about what the differences are in serving a pediatric population when treating dermatology-related conditions, if there are any?
There's lots. I think the very first thing is, when you're seeing children, you don't have one patient, the whole family is your patient. So that's kind of the very first thing. I think your communication style is very different when you're talking to an entire family. I think your risk benefit or benefit risk conversation is also very different when you're dealing with babies. Parents are naturally protective over their children and don't want any harm to come to them, which is totally understandable. Of course, that's what we want, but we have to kind of convince the parents that skin disease is worth treating. To me, one of the biggest differences is, especially because I've been running my psoriasis clinic for many, many years now. The biggest thing I see is this change in personality, which you don't get as much in adults. So I feel like adults are fully formed people. I mean, of course, we're still improving their quality of life, of course. And patients will tell you that. But it's the fulfillment of seeing, a young kid or a preteen who has bad skin disease, clear them and see how they develop into these like fully fledged adults almost without their skin disease, almost without, their lives being, of course, it affects their lives, but it doesn't change their lives anymore. To me, that is the most fun part of pediatric dermatology. That's the most fulfilling part of pediatric dermatology, and really, really, really gives me so much joy.
It must be incredibly rewarding getting to see that change, and then that change probably sticks with the patients for the rest of their life because they are so young. So they're learning to manage it for many, many years to come.
Yeah, I've had patients that have gotten married. Some of them are firefighters, policemen, ER nurses in the hospitals. Like, it's just so nice to be able to offer someone like a full life without having their skin disease hinder kind of their aspirations and the course of their entire life.
I think that makes so much sense. A question I had about pediatrics specifically and in relation to dermatology is, I know that kind of across the medical field, it seems like when like clinicians talk about using interventions and new medications, it's always tougher to get those medications into the pediatric populations just because of like clinical trials, and I know that people are maybe more rigorous or there's more rules in place when children are the subjects. Has that been an
Mhm.
issue in your practice at all? Is it harder to get interventions that you see working well in adults being able to be used in pediatric populations?
That is an issue. We use a lot of things off-label, but sometimes it's also a matter of you can't get it covered, especially for the more advanced medications that are expensive. You can't get them covered in a younger patient, let's say. Um, Luckily, that's starting to change. I mean, of course, the pediatric indications are always going to come later than the adult indications, unless it's something specifically made for a pediatric disease. But let's take psoriasis as an example. For the biologics, it really is a trickle-down effect. You know, you get the indication for the adult population first, and then it sort of they do the clinical trials in kids. Um, before before we had anything approved for kids, we would use some things off label, but it's always much harder to take that chance. You know, like it's much harder to get buy-in from parents. It's much harder to get buy-in from payers when that happens. And I do feel it is a very big unmet need in the pediatric population, that it takes years and years and years after a drug is approved in the adult population for it to transfer to the pediatric population. Luckily now, let's say for atopic dermatitis, a lot of the clinical trials start from 12 and up. So, but still, I mean, atopic dermatitis can start very, very young. And sometimes it's taken years for drugs like biologics to kind of trickle down to the younger patient population. So it is a challenge, definitely. It's the same with pregnancy. Nothing is in clinical trials for pregnancy, at least for dermatologic conditions. So that's the same challenge. It's this, you know, how do you play with the tools that we have without putting the patients in the path of undue harm?
That's definitely an interesting consideration to think about. And with the pregnancy as well, you know, a lot of pregnant people may be nervous to continue their medications, but then not treating and having the disease flare is also really dangerous. So I can imagine it's difficult to figure out the risk-benefit analysis for that.
Yeah, definitely. I mean, the instinct for any woman who gets pregnant is to just stop all their medications. And particularly for skin disease, they think, oh, it's just my skin. I can't possibly be on medication for this. But you're right, not recognizing that not treating the skin disease could put their pregnancies and their mental health and their well-being at risk as well. So a healthy mom is a healthy baby.
I always find those studies especially interesting to read because more and more are coming out that's showing it's not just an aesthetic thing, that it affects other organs and that inflammation can go widespread and uncontrolled if not under medication. So definitely an interesting thing to think about. Something that we wanted to also touch on, because you had so much experience working with students and learners, is what you think that all students should know before pursuing a career in dermatology.
I think the first thing I'm going to say is do it for the right reasons. You have to love the specialty. Um, we see a lot of patients. And so if you don't like talking to patients, that may be an issue. I don't think people realize how many patients we go through on a daily basis. So it is tiring that way. You deal with a lot of people. So if you don't like people, one, it's tough to be a doctor if you don't like people, but it's particularly tough in a high volume specialty like dermatology. So there's that. Um, I also recognize that it's very difficult to get clinical experience in dermatology outside core rotations, if you even have core rotations, because sometimes dermatology is not even part of the curriculum. But it is, I think, if you're interested in it, it is important to have exposure to the specialty early on to see if you like it or not. I think one of the unfortunate realities is sometimes people don't get exposure to dermatology until very late, let's say in med school, and are not able to build kind of the relationships or experience that they need to for application, let's say. Or conversely, there are people who think, oh, I want to do dermatology, and they start really early on, and then they realize towards the end, I don't actually like this. So um, it's important, I think, to look at everything, but make sure when you're deciding to not get kind of pigeonholed, and to keep an open mind about the experiences that you're going to have.
think that's great advice specific to dermatology, but it could apply for all of our learners too, to everything they do throughout medical school, to just
Yeah,
keep
for sure.
try out as many different specialties as you can when you have that opportunity.
Yeah.
This next question, kind of building off of that one, we wanted to ask you as well is, since you do work with students and kind of learners all the way through their educational experiences, do you have any advice to give to the listeners on how maybe they can act or how they can be a productive member of the team during their dermatology placements?
Like when you do your dermatology rotations, whether it's core or elective, I think we recognize as educators that everyone is coming from a different space, right? Like there's some people, they've done like 3, 4 electives in dermatology already. And so the base knowledge is somewhat there already. But sometimes we'll get learners who are like, this is their first dermatology experience, and neither is good or bad. I think the opportunity for teaching and learning is there for both scenarios. And so I think just being sensitive to the needs of the team, like for example, if the clinic is running really behind, like be sensitive to that and maybe ask the questions after the clinic. Try to be as helpful as possible. Obviously, we don't expect medical students to help with like procedures, but bringing patients into rooms or helping residents out when they're doing a procedure, something like that. I think just being sensitive to what is going on around you, because in dermatology too, you can have rotations in academic dermatology, so academic sites, which function very differently. You can also have rotations in a community dermatology clinic that functions very differently as well. And so I think being really, it's almost like having that gut feel or that intuition into where you would fit in well with that team, and not trying to coming into it with an open mind with your dermatology electives or rotation.
It seems like that's pretty consistent with the general advice that we've received on the podcast, is just trying to be in tune with the team's needs and being as helpful as possible, recognizing that it's a very busy day, to summarize, if you would agree.
Yes. I mean, we are happy to teach. Sometimes I feel bad because the clinic is so busy, and we have sometimes, like right now, I have a learner from internal medicine, let's say, and I would like them to have kind of the best possible experience. But if you're, running behind, or we have fit-ins for, patients who were referred from the ward, it's a little tough. So sometimes we have to do that after, or maybe cut the teaching short to like, case-based learning.
We also know that you're quite involved in research, and so we wanted to ask your perspective on if you had any insight on what you think the biggest issue facing the field of dermatology is right now.
I think so. I don't do a lot of basic science research. I do kind of more clinical research. Um, I think one of the biggest issues is, and it's not just in research, but in a lot of aspects, dermatology as a specialty is sort of undervalued. And so a lot of the research is coming from, let's say industry sponsored research, because that's where a lot of new development is. But there's still so much we need to learn for many, many diseases. I think in dermatology, we have over 1,000 diagnoses. So that's the other interesting but challenging thing about the specialty. And so, if you have drugs for, let's say, 10 diseases, what about the 990 other diseases? What are we going to do for that? And we don't have randomized clinical trials for that. But who's going to fund those studies? Who's going to do the studies? And so I think that is challenging. It's also challenging because we can't get, like in cardiology, the cohort is 10,000 patients, let's say, and that's a small study in cardiology. We don't get that in dermatology. And so maybe the best data you have is out of 300 patients, and that's already kind of robust clinical trial data. So I do think it's tough. I think research in dermatology is relatively young. So there's still a lot to be done in research.
I think that all makes sense. And I guess a lot to be done. Well, you can look at it maybe glass half empty. I guess the glass half full is there's lots of room for all of the up and coming dermatologists to get involved in research that way, which is always a nice thing as well. Something you said kind of sparked a question for me is you were talking about how there's like 1,000 different diagnoses in dermatology and things like that. I'm actually currently where I am in my curriculum right now, we just finished up we have 2 weeks of straight dermatology in our curriculum. And
Mm-hmm.
I knew there was a lot of different diagnoses, but then seeing all the pictures, I was kind of even more blown away than I thought. So I was wondering if you had any tips for learners who are just getting introduced dermatology curriculum. How do you learn and how do you get better at identifying skin conditions?
Um, Morphology, which is kind of like the cornerstone of diagnosis in dermatology, is a skill. The more you do it, the better you get at it, right? Like, let's say you like birding. The only way you're going to get to know the different kinds of birds, I don't do birding, so maybe this is wrong, but like if you had an interest in something that required you to recognize characteristics of a particular bird, let's say, in order for you to like recognize that bird from afar in 2 seconds, you have to keep doing it. You have to read about it. And so that's sort of like, it's funny because in dermatology, patients will always ask, well, how do you know it's that? And I actually don't know how to answer that question because that's what we do. That's what the specialty is about. So I think I lost my train of thought, but I think just keep doing it, keep looking at pictures, keep noticing details. You have to notice the details. Obviously, as a medical student, this is why dermatology residency is so long. That's why it's not a year, is because you have to sort of fine tune your eyes to see the details that make one disease different from another. And it's a skill. It takes practice. It takes time. It takes exposure. That's why it's also very hard to teach dermatology in medical school because it's very difficult to learn dermatology by just reading and looking at pictures. Um, it's you have to keep seeing things and reading around things. And as you read about something that you saw, that integrates that knowledge and allows you to recognize when something is not that. And then if something is not that, then you think, okay, if it's not that, what else could it be? And then you dig deeper. It's a very interesting specialty that way, in that we don't have a lot of algorithms. We don't have a lot of, like, we can biopsy, but a lot of it is really our eyes and our clinical judgment.
I think that's one of the things that is so special to highlight about dermatology, which one of the things we're going to ask you is to tell us your favorite and least favorite part soon. But I think that a lot of the people who have pursued dermatology, from what it sounds like, really enjoy that puzzle mystery component of the specialty where you really have to practice and get the hang of the little details to tease out apart a larger diagnosis.
Yeah, that is one of the most fun parts of the specialty. It is fun to have 1,000 differentials. Not for every single patient, but it is fun to learn about that. It's also really nice to be able for patients to see themselves getting better. I think it's very different if you're watching a lab value go down. Patients might feel the same, and there might be a sense of satisfaction for some patients, just watching their labs go down. But there's nothing like seeing your skin go from covered in psoriasis to zero psoriasis. Um, Patients often can't believe that when we tell them that. When, let's say, they've lived with psoriasis all their lives and they come and I say, we actually have drugs that can clear you, like zero psoriasis or maybe one spot. And that almost like they cannot grasp that concept. And so when you see them after and they're better, they have no more blisters from bullous pemphigoid, or you've cut out their skin cancer and or you've sent them for skin cancer and they've cut it out and repaired it really nicely, or they're not itchy anymore. That's a very tangible thing for patients. And I don't know if there's any other specialty where patients can actually like watch their disease get better. So that's the most fun part of the specialty.
Well,
In terms of the
I was
no,
just
go
going to say
ahead.
I very much appreciate that answer. And I was just going to ask you to follow up, but you were doing it already in terms of your least favorite part of the specialty.
The least My least favorite part of the specialty is that this undervaluing of the specialty kind of integrates into so many aspects of it. I think people don't recognize the importance of dermatology until they actually need a dermatologist. And then people are like scrambling, I can't get one. And that's because there's so few dermatologists across the country. And that's, I think, because it's undervalued as a specialty. People think, well, we don't need that many dermatologists. But like in family practice, studies have shown anywhere from 10 to 30% of patients come in with a dermatologic condition. And especially if you get like a really severe skin condition, it's even harder to find a dermatologist with expertise in that specific skin condition. So I remember I had a cousin before who, when he realized that I worked in a hospital, he was like, well, what do you see in the hospital? Like, why are you a dermatologist in a hospital? Like, and he's a physician too, and he almost couldn't grasp it until one day he had a patient who had vasculitis. And so he practices in the US, and he was like, what is this? So I think until people need a dermatologist, they don't actually recognize how important or how cool a specialty it is.
That sounds like exactly what happened to me recently on one of my clinical placements, where a patient just started developing a few papules, and then the next day he had a few more, and then on the third day he had a whole body, and there was no dermatologist in the hospital to consult. We're all like, so now what? And I think that you don't really realize how fast the condition progresses, and it ended up being vasculitis, interestingly enough.
Yeah.
But immediately when they were placed on the prednisone, you saw that improve, but just right before that, it was so alarming to the patient, because they were like, well, how much more of this is going to show up, and like how much more of my skin can start being affected? So I definitely feel like that's something that really resonates with a recent experience.
Yeah, I mean that part of the kind of non-recognition of the value of the specialty is that there are a lot of hospitals that don't have a dermatologist on staff or on call, and it's shocking how many hospitals deal with complex patients but don't even have someone to refer to if the patient has an adverse cutaneous drug reaction. So it's hard. It's almost like there's so many levels that you have to convince that, hey, you need this specialty.
Probably a mission a little bit outside skin curriculum, but our mission is to get a dermatologist into every hospital in Canada.
I fully support you. Fully support that mission.
Okay, so our final question we have before we move into our second segment, which is just our get to know you questions, is we were wondering if you had any last piece of advice or last pieces of advice for our learners or anyone currently pursuing this path right now.
I think stay focused. It's tough. You will because there's not a lot of places where you can get clinical experience outside your core rotation if you're lucky enough to have one. Just be persistent, and don't get discouraged, because sometimes you might not get a response from the someone you're emailing. But that's, I mean, I'm sure you guys know how busy things are, but keep trying. And once you see an opportunity, take it and just make the best out of that opportunity. I think that's true for not just dermatology, but for everything. I don't think there's anything specific that you really need to do for dermatology. There.
Thank you so much. I think that's a great last piece of advice to leave us on. Just be persistent and don't let things get you down, is what I took from that.
Yeah. Yes. Don't take things personally. It's not because if you don't get a reply from the dermatologist that you're emailing, it's not because they don't like you. It's just probably, like they've received 20 other emails, or we just can't take, like in Sunnybrook, let's say for observers, we have very, very, very limited, almost zero spots for observers actually. Just because we have core, we have electives, we have selectives, we have residents, off-service residents. Like there's just so many learners. So yeah, don't take it personally. Be persistent. It's not you. It's the system. We're sorry.
Well, on that note, why don't we jump into some of our fun rapid fire questions just to end off the episode on a fun note. So our first question is, what is your favorite thing to do on a day off or on the weekends where you're not working?
I like to cook. That's my relaxation. I love to make complex all-day meal projects when I have the time. What I love to do.
Your family is very lucky then. I hope they know that.
They help clean up.
That's a fair deal. And what kind of things like have you recently made? What complex dishes?
So I'll cook anything. I'm a very adventurous cook. But the last thing I made 2 weekends ago was this. It's like 1,000-layer potatoes. So you like slice potatoes very thinly. You bake them, put them in the fridge overnight, slice them up, and then fry them. So the potato is like a cake, but it's like many layers of very, very thin potatoes that's crispy on the outside and soft on the inside. Yeah, that was like a project, but worth it.
Well, it sounds so good. Being able to make it for yourself, but maybe with some practice. Our next question for you is, we were wondering if you had a favorite place to travel.
So I have two favorite countries, aside from the Philippines, of course. That does not need to be said. I love Spain and I love the Netherlands. So those two places I really love. I think for Spain, it's because I love their food, and I don't know if this is common knowledge, but the Philippines was under Spanish rule for 350 years. So that culture is very familiar to us. And so just going there, it feels like almost like being home in Spain. And I love that there, like every region is different. There's beach, there's mountain, there's everything in Spain. And then the Netherlands, I don't know, like that country just works. Everything is so thoughtful about their urban planning and their way of life. And I don't know, I could live in the Netherlands, I think.
And I'm sure Canada is somewhere on that list.
Well, I don't have to travel to Canada, so I'm here.
That's true. I guess we didn't say favorite country, so you're completely right.
Yes, yeah.
And our last question, which coincidentally somehow kept on the theme of food, is what is your favorite dessert or sweet treat? And this could be something you like to eat or something you like to make, now that we know that you like to cook.
That's tough. Because I generally like savory things more, but I do like my cheesecake. There's that, the cheesecake I make, and also churros from Spain, not the Mexican ones, the Spanish ones.
Okay.
They're quite different. So like when I go to Spain every day, twice a day, I will have it. So that's like you dip it in hot chocolate, and it's like fried dough and hot chocolate. What could be better than that?
The recipe to magic in my eyes.
Yes, exactly.
Well, on that note, we wanted to say a huge thank you to you, Dr. Lansang, for taking the time to speak with us today. We're so appreciative of your time and all the advice and insight you shared with us today. And that brings our episode to an end. So to all our listeners, thank you so much for listening. If you want to keep up with our podcast, offer us any feedback, or know when we post our next episode, you can follow us at Skin Curriculum on Twitter or Instagram. And you can also find us on our website at www.skincurriculum.com. Otherwise, we hope you enjoyed this episode of Dose of Derm, and we hope you all take care.